I want to start today with something personal. I have spent years reviewing medication lists with patients and their families, and there is a specific moment that happens in those conversations. A moment where someone looks at the list, looks at me, and says some version of the same sentence. But I have been taking that for years. My doctor prescribed it. It must be fine. That moment is why I made this video. Because there are 5 medications that millions of adults over 70 take every single day, some available without any prescription at all, that carry a documented, research supported risk profile that is fundamentally different in a body over 70 than it was in that same body at 50. And the reason most people do not know this is not because doctors are hiding it. It is because a 15-minute appointment under time pressure almost never produces the depth of medication review that an older adult genuinely deserves. I'm Dr. Elena Pierce, and I want to be clear about what today's video is and what it is not. This is not a list designed to frighten you away from medications you need. Every medication on this list has legitimate uses and has helped real patients. What I am doing today is giving you the specific research, the specific risks, and the specific questions that allow you to walk into your next appointment as an informed participant in your own care, not a passive recipient of a prescription. Subscribe if you haven't already, because this channel exists precisely for this kind of conversation. Now, let me tell you why the body over 70 is fundamentally different territory for medications, because this biological context underpins everything else I am about to share. After 70, your kidneys filter drugs from your bloodstream measurably more slowly than they did at 50. Your liver metabolizes compounds at a fraction of its earlier rate. Your body composition has shifted, less muscle, relatively more fat, which changes how fat-soluble medications distribute and accumulate. And your brain has become significantly more sensitive to sedative compounds and to drugs that interfere with neurotransmitter function. A dose that was safe and appropriate at 55 can now cause falls, memory impairment, kidney damage, and cognitive decline that presents in ways that are indistinguishable from early dementia. This is not theoretical. It is the reason the American Geriatric Society maintains a document called the Beers Criteria, a rigorously reviewed, regularly updated list of medications considered potentially inappropriate for older adults. Every single medication I am covering today appears on that list. This is mainstream geriatric medicine, and it is reaching the people who need it most far too slowly. The first medication is one you almost certainly recognize by its brand names: Xanax, Valium, Ativan, Clonopin. The drug class is benzodiazepines, and they are prescribed primarily for anxiety and insomnia. They work. That effectiveness is part of what makes them so widely used, and part of why they are so consistently problematic in older adults. After 70, the brain's sensitivity to benzodiazepines changes significantly, and because the liver now metabolizes these drugs more slowly, they accumulate in the system. A dose designed to help you fall asleep at 10 in the evening may still be meaningfully impairing your coordination and reaction time when you get up at 3 in the morning for a glass of water. Multiple systematic reviews confirm that benzodiazepine use is associated with a substantially increased risk of injurious falls in older adults, falls serious enough to require emergency care. And falls are the leading cause of fatal injury in adults over 65 in the United States. We are not talking about a minor inconvenience listed in fine print. We are talking about the medication being a direct contributor to a leading cause of death in this age group. Beyond fall risk, benzodiazepines consistently impair memory, attention, and executive function in older adults, even in patients who feel they have fully adapted to the medication and no longer notice any effect. The cognitive impairment is happening whether or not it is subjectively felt. The American Geriatric Society explicitly lists the entire benzodiazepine class on the Beers criteria as drugs to avoid in older adults. If you are currently taking any benzodiazepine, I need to say something clearly before we go further. Do not stop this medication on your own. Abrupt discontinuation of benzodiazepines can cause serious withdrawal symptoms, including seizures that are genuinely life-threatening. This is a supervised, gradual taper that must be managed by a physician. Use this information to start a conversation, not to open your medicine cabinet and make a unilateral decision. The second medication genuinely shocks almost everyone when I explain the research behind it, because it costs around $6 at any pharmacy and requires no prescription whatsoever. Diphenhydramine, sold as Benadryl for allergies, and sold as the active sleep ingredient in ZQuil, Unisom, and Tylenol PM. Millions of adults over 70 take this every single night, completely confident that an over-the-counter product available everywhere must be safe. For a body over 70, it is not. Diphenhydramine is one of the most potent anticholinergic drugs available without a prescription. Anticholinergic means it blocks acetylcholine, the primary neurotransmitter your brain uses for memory, learning, and cognitive function. A landmark study published in JAMA Internal Medicine in 2015 followed 3,434 adults aged 65 and older for over 7 years. Researchers found a clear dose-response relationship between cumulative anticholinergic drug use and the development of dementia. Those in the highest cumulative use category had a 54% increased risk of developing dementia compared to non-users. The most common anticholinergic drugs identified in that study were first-generation antihistamines, exactly like diphenhydramine. A 2019 study in the same journal examining nearly 60,000 dementia patients corroborated those findings. The evidence has continued to build consistently every year since. Eleanor was 71 years old and had been taking 2 Benadryl tablets every night for nearly 5 years. Her doctor had actually recommended it for sleep. Over those years, her family watched her become increasingly forgetful. Repeated questions, confusion in familiar places, words lost mid-sentence. A new physician reviewing her complete medication list flagged the diphenhydramine immediately. Over the following 7 months after she stopped taking it under medical guidance, her cognitive test scores stabilized and partially improved. Her daughter described it as getting a piece of her mother back. The change was noticeable. The third medication is the one that tens of millions of seniors reach for the moment their knees or back flare up: Ibuprofen and Naproxen, sold as Advil, Motrin, and Aleve. These non-steroidal anti-inflammatory drugs are the first response to pain in most households, and for occasional use in younger adults, they are generally manageable. For regular use in adults over 70, the risk profile changes entirely. By age 70, kidney function has typically declined by 40 to 50% compared to young adulthood. When ibuprofen circulates in a body with already reduced kidney filtering capacity, it lingers longer, concentrates more intensely, and progressively damages the tissue responsible for clearing it. The 2023 update to the Beers criteria specifically reinforced the need for kidney function-based dose adjustments for NSAIDs, explicitly recognizing how frequently this drug class causes acute kidney injury in older adults. The gastrointestinal risk is equally serious. According to the National Institutes of Health, older adults who use NSAIDs regularly are 3 to 5 times more likely to develop a serious gastrointestinal bleed than younger users. For adults with heart disease or high blood pressure, NSAIDs additionally raise blood pressure and increase fluid retention, elevating heart failure risk. That combination, kidney damage, gastrointestinal bleeding, and cardiovascular risk, makes ibuprofen and naproxen as a daily or near-daily habit after 70 one of the most consequential unaddressed medication risks I see in older adults. And because these drugs are sold freely over the counter, most patients and many physicians do not think of them as something requiring the same level of scrutiny as a prescription medication. The fourth medication is prescribed to roughly 10 million Americans annually for sleep: Zolpidem, sold as Ambien. The FDA issued a specific safety communication about this drug in older adults, noting that elderly patients can have far higher blood concentrations of Zolpidem the morning after taking it compared to younger users taking the identical dose. This means they are still pharmacologically sedated when they wake up, without feeling or knowing it. Their coordination and reaction time are compromised while they feel completely normal. Research consistently finds that Zolpidem use is associated with nearly twice the risk of hip fracture in older adults, and the 1-year mortality rate following a hip fracture in adults over 70 is 20 to 30%. That means up to 3 in 10 seniors who break a hip may not survive to the following year, most often due to complications such as blood clots or pneumonia during recovery. There is also a specific pharmacological problem with Zolpidem that makes its continued use self-perpetuating. The drug suppresses the deep restorative stages of sleep while increasing lighter sleep stages, so you fall asleep faster, but you wake up feeling less restored than genuine sleep would provide, which drives the perceived need for continued use, higher doses, and dependency. It solves nothing. It changes the shape of the problem while making the underlying sleep architecture worse over time. Here's exactly what you should do. First, write down every medication you take, prescription and over the counter. Yes, include the Benadryl, the Advil, the Prilosec. Over the counter does not mean safe. Second, bring that list to your doctor and ask specifically for a geriatric medication review with evaluation against the American Geriatric Society Beers criteria. Those exact words will be immediately recognized by any physician. Third, for pain, ask about acetaminophen as a first-line alternative. It is significantly safer for kidneys and the GI tract at the correct dose, no more than 3,000 milligrams per day for adults over 65. Fourth, for sleep, ask for a referral to cognitive behavioral therapy for insomnia, known as CBTI. Research consistently shows it outperforms every sleep medication for long-term outcomes: 0 drug interactions, 0 dependency, no morning impairment. Fifth, if you have been on a proton pump inhibitor for more than 6 months, ask whether you still need it and whether your B12 level has been checked recently. A critical safety note: do not stop any prescription medication without speaking to your doctor first. Benzodiazepine withdrawal without medical supervision can cause life-threatening seizures. Every medication change requires coordinated medical oversight. Use this information as the basis for a better conversation, not a reason to act alone. These 5 medications are not automatically dangerous for every person in every situation. But in adults over 70 used long-term without reassessment, the research is consistent. Your body has changed since you first started taking some of these drugs. Your medication list may need to catch up. Comment below with one of 3 responses. Comment reviewing my list if you are checking your medications today. Comment your age and which of these 5 you want to discuss with your doctor. Or comment sharing this if you are sending this to a family member who needs to see it. I read every comment. I'm Dr. Elena Pierce. Subscribe now. Next week, I am covering the 3 blood pressure medications quietly damaging kidneys in adults over 60 and the specific blood tests that catch the damage before it becomes permanent. Take good care of yourself.